Good afternoon, everyone. I am Professor Martha Cohen, a Vice President for Learning for the Royal College of Pathologists, and I welcome you all to our fifth webinar on challenges and novelties in pediatric pathology. This has been organized by the Royal College of Pathologists, Virtuous Archives, the European Society of Pathology, and the International Paediatric Pathology Association, IPA. It is my pleasure to introduce my friend and esteemed colleague, Professor Miguel Reyes Mujica, who will moderate this webinar. Everybody knows Miguel. He needs no introduction, but he is, just to summarize, he's a professor in pediatric pathology at Miami University, and he was key, together with Dr. Isabel Colmenera, as editors of this special issue of Virtuous, to put pediatric pathology and pediatric tumors on the spot. And he's also an editor of the WHO Blue Books. So thank you, Miguel. The floor is yours.
Thank you, Marta. Very kind of you. It's a pleasure to welcome everybody to the fifth webinar on novelties and challenges in pediatric pathology, addressing a special issue published by the Virtuous Archive journal in the beginning of this year. Today we have two conferences. The first one will be delivered by Drs. Gino Summers and Maureen O'Sullivan. Dr. Gino Summers is the chief of the Department of Pediatric and Laboratory Medicine at the Hospital for Sick Children, or so-called sick kids, as they call it. He's a professor at the University of Toronto and has conducted significant research, well-funded research, and described many new things and contributions to pediatric pathology. His bio is available in the Royal College link for these webinars. I will not detail his accomplishments because then it will take the full hour. After him, Dr. Maureen O'Sullivan will follow. She's also a very well-known pediatric pathologist in Dublin and a consultant for the Pediatric Pathologist Children's Health Ireland since 2007, has made significant contributions to the biology of pediatric renal tumors, and we will look forward to listening to her contributions. Gino, you start. Thank you very much. We will have a question and answer session at the end of the hour.
Wonderful. Thanks so much for those kind words, Miguel. Much appreciated. So yes, we're going to be talking about pediatric renal tumors, Maureen and myself, for the first half of this webinar. And I'll be talking about Wilms tumor. And what I'd like to cover in Wilms tumor is the histologic characteristics and the pathologic classification, as well as some of the challenges and some recent developments and things to look forward to. So Wilms tumor itself is the most common pediatric renal tumor, accounting for up to 90% of kidney tumors in children. It affects children between the ages of 3 and 5. That's the most common age group, although you can see tumors in a younger cohort and in an older cohort. We'll talk briefly about those. Basically, Wilms tumor is a tumor that shows abnormal fetal kidney development, and it can be associated with nephrogenic rests or just foci of remnants of developing kidney. It's the classical triphasic tumor. It's comprised 3 cell types: blastema, epithelium, and stroma, or mesenchymal elements. And at least 15%, probably quite a bit more, are associated with cancer predisposition syndromes. And these tumors tend to be bilateral, multifocal, and occur in a younger age group, and often are associated with nephrogenic rests. I just want to spend one slide speaking about the 2 management strategies, because it's kind of important when we start talking about the histologic classification. The 2 management strategies are essentially the COG, or National Wilms Tumor Study Group, which works with essentially upfront resection. So this is before chemotherapy. and that's predominantly North American. The other is PSYOP, or the renal tumor study group, and that's upfront chemotherapy followed by resection. So on the one hand, you get a tumor that's not been treated. On the other hand, you get a tumor that's been treated. And obviously the pathologic classification differs somewhat for those two. Interestingly, the event-free survival and overall survival, regardless of what approach you take, are very similar. Just some images to remind us what a Wilms tumor looks like. This is the classical triphasic histology. You can see in the upper center, we have blastema, we have epithelial components manifested by these primitive tubules, and this loose mesenchyme, which is the stromal element. Another photo of mesenchyme, this time a little more edematous, with some anaplastic change within that mesenchyme. And in the inset, you can see one of the classical features that you sometimes see in stroma, which is rhabdomyoblastic differentiation. Do not mistake that for rhabdomyosarcoma. Can be a little challenging on a core biopsy. This just shows a little bit of a closer view of the blastema. This is nodular blastema. You can see lots of mitotic activity, which is not unusual, quite common in these areas. And then an epithelial component, quite obviously seen here as tubules of different shapes and sizes. This slide shows anaplasia. Anaplasia is an incredibly important feature to recognize, as it carries significant prognostic impact. On the left, you can see cells that are hyperchromatic and at least 3 times the size of its neighbor, which are 2 of the characteristics. And the third characteristic is seen on the right panel with an atypical mitotic figure. And finally, this is an image of a nephrogenic rest. The nephrogenic rest in this instance sits just beneath the capsule. This is what we would call a perilobar nephrogenic rest. And you can see the elements abut the normal kidney. There's no capsule. Whereas in Wilms tumor, you have a capsule surrounding the tumor. And that's one of the differentiating features of nephrogenic rests versus Wilms tumor. So how do we histologically classify Wilms tumors? Well, according to PSYOP, there are 8 different subtypes based on the percentage of therapeutic response and viable tumor elements, as well as the presence or absence of anaplasia. In the COG protocol, it's a little more straightforward in that it's either a cystic partly differentiated nephroblastoma, which is the low risk. There's the presence of anaplasia, which is high risk or unfavorable, and then there is the absence of anaplasia in a classical Wilms tumor, which is called favorable histology. In both systems, there are 3 different groups: low, intermediate, and high risk. And again, just to belabor the point, that is based upon the histologic subtype and the presence or absence of anaplasia. So histologic subtype, anaplasia, very important for histologic classification. And how do we prognosticate? Well, the features differ between the 2 groups, but there are some common features. And 2 of the most important common features are local stage and presence of anaplasia. And local stage really relates to the anatomic extent of the tumor and the completeness of excision. For example, tumors confined to the kidney have a much better prognosis than those that extend beyond the confines or metastasize locally or distantly. And the presence of anaplasia, up to 10% of tumors show anaplasia. Those with anaplasia have a worse prognosis and often are associated with P53 mutations. Diffuse anaplasia, where it's everywhere, is associated with a poorer prognosis than your ones with no anaplasia, significantly so. So that's COG. Well, what about that's the common features between COG and PSYOP. But what about the specific features for PSYOP? Well, we have the histological stratification into the 3 risk groups that we spoke about on a histologic level. Tumor volume is also important, and the degree of change after therapy, and the responsiveness of lung metastases. Those 3 features help prognosticate. In COG, again, it's a little more complicated. It's kind of the opposite of the histologic classification, where it's a little more simple. But in COG, increasing patient age is associated with an increased risk of recurrence and worse outcomes. This is regardless of the presence of anaplesia, because we know in older children anaplesia is more common. But if you remove those tumours and compare favourable histology to a younger cohort with favourable histology in older children, the older children still do worse. Tumour weight is important. Again, rapidity of lung metastases response, but this time in a wider group than just for PSYOP. And one of the things that is in the COG protocols for prognostication, but is not yet in PSYOP, are genetic alterations. We know that loss of heterozygosity in certain regions, 1P and 16Q, as well as gains of 1Q, are associated with increased risk of relapse and a shorter event-free survival. And my last slide is recent developments. So you can see that there are 4 points here that I just want to spend a short amount of time on. The first is, with the 2 management strategies, there are 2 staging systems. There's a publication that's recently been published by the International Collaboration on Cancer Reporting, ICCR, that harmonizes the 2 into one document. And that's really useful for centers that, for example, perhaps don't see a lot of Wilms or might see a mix of treated and non-treated resections. It brings it together. It has a lovely comment section at the end, and the link is in the slide. You can see there. Genetic work has identified several potential driver genes, TRIM28 being one of them, and that's important in both sporadic and a growing number of familial Wilms tumors are seen to have mutations in TRIM28. The other really interesting point about some of the genetic studies that are coming out is that Wilms tumors are incredibly heterogeneous on a genetic point of view, from a genetic point of view. And that suggests that there are different subgroups, different drivers, and perhaps different optimal therapeutic regimens within even a single subgroup of Wilms. Much more to come on this front. And I think the genetic work will really help solidify the best treatment protocols. Another exciting development is surgical approaches. Certainly for patients who have tumor predisposition syndromes or who have multifocal Wilms tumor, the surgeons are doing their very best to do nephron-sparing surgery, where you remove just as much of the tumor as you need for clear margins. And we've seen that certainly here at Sick Kids. And marginal status there is incredibly important for obvious reasons. And that gives the child a much greater chance of being able to use their kidney for their renal function before they need transplant or some other method of replacement. And finally, the remaining challenges include those children who undergo refractory relapse. So tumors recur and generally are refractory to many modes of therapy. These children remain a challenge. They're a small group, but they remain a big challenge. As do children with high-risk histology. The oncologists are still trying to find optimal therapy, and balancing aggressive treatment with comorbidities and morbid outcomes due to that treatment, because in young children, obviously chemotherapy has devastating effects sometimes and long-term effects. Perhaps the genetic alterations will help target therapy a little better. So there's a quick walk in the park through Wilms tumor, the histologic characteristics, the challenges, and the two different management systems, as well as some of the recent developments. I'm going to hand over to Maureen now to talk about non-Wilms kidney tumors. Thank you, Maureen.
Thank you very much, Gino. So let's see if I can share my slides here. So thank you very much, first of all, to Marta, to Miguel, and to Isabel for the opportunity to speak about renal tumours here today. I'm always happy to speak about renal tumours or sarcomas to anybody who will listen. So picking up from where Gino has just finished on nephroblastoma, I'm going to speak about the approximately 20% of paediatric renal tumours that fall into the non-Wilms categories. So the main entities I'll cover today, quite briefly because of the time restriction, include clear cell sarcoma of kidney, malignant rhabdoid tumor of kidney, congenital mesoblastic nephroma. There have been some updates in renal carcinomas, which I think are important to share, and then renal medullary carcinoma, which is still a dismal tumor. There are other entities that also occur, such as PNET, which occurs with some degree of frequency, primarily within kidney, and other sarcomas, but in the interest of time, I will not be able to go through those. So clear cell sarcoma of kidney was first recognized as being a separate entity from all of the pediatric renal tumors that were studied together in the group that was mentioned by Gino, the NITWITS group, or the North American Wilms tumor study group, because these tumors behaved more aggressively and had a propensity to metastasize to bone. So this gave them the name bone metastasizing renal tumor, which obviously we don't use anymore, but it gives a clue as to the biology. These tumors occur in a similar age group, perhaps a little younger, between the ages of 1 and 5 years, and are far more common in boys than in girls. So more than twice as many boys are affected as girls. And often the presentation is with either already stage 3 or indeed stage 4 disease. And whereas Wilms tumor stage 3 all comers will have a 92% overall survival, this is 73% for CCSKs in stage 3 and a rather dismal 29% for those presenting with stage 4 disease. For us as pathologists, there is a very highly variable morphology associated with CCSK, and 9 different patterns have been described. So until such a time as we understood a little bit more about the genetics of this tumor, and indeed from that we're able to derive an immunohistochemical panel that was useful for us to use, this was quite a challenging diagnosis for pathologists. It has become a little bit easier since these two areas have developed. The first insights really came with the characterization of the 1017 chromosomal translocation. And it was in fact my research group that published this. It's a 1433 epsilon not M2 fusion that results from this translocation. And subsequently in 2016, the importance of the BCOR gene became obvious. From these publications and further study of the gene expression profiles of these tumors, we were able to devise an immunohistochemical panel that is very useful for adjunct diagnosis of CCSK. And this includes BCOR, TLE1, and cyclin D1, all 3 of which should show strong diffuse nuclear reactivity within CCSK cases. Here I'm showing you just 4 of the 9 patterns that have been described for CCSK. So the top left perhaps is the most classic appearance, and this is where CCSK got its name. It's in fact the clearing of the nuclei that's important in this tumor to be called clear cell sarcoma. And this is an epithelioid appearance with ovoid nuclei that are very monotonous. On the upper right, we see a spindle cell lesion with some buckling of the nuclei, perhaps giving it a somewhat neural appearance. Bottom left is very myxoid, and bottom right is a very sclerotic pattern. So clearly this tumor can exhibit many different faces, and sometimes several of these within the one tumor. So over a 20-year period, 3 individual case reports were published that showed this 1017 chromosomal translocation in individual cases of CCSK. And from this particular case, published in 2007, we approached the authors and got material, and then proceeded to characterize what exactly was going on at the breakpoints of these chromosomes, and were able to show that the fusion gene was a gene called YAWE, YWHAE, not M2, producing the 1433 epsilon not M2 fusion protein, and we published this back in 2012. We then actually made a cell line model system wherein we could selectively express this fusion gene, and through that we were able to show that the oncogenic effect is through dysregulated MAP kinase signaling in this situation when the fusion was expressed. But the fusion is present in, at the very most, 12% of CCSKs. And so the question remained what was going on in the remaining cases. And this was cracked by a Japanese group, first published in 2015. And in a series of 20 cases, they found an internal tandem duplication, so just a repeat of part of the normal sequence, within the final exon of the BCOR gene. And they found this in 20 out of 20 cases that they studied. None of those cases showed the 1433 epsilon not M2 fusion. So we then gathered together, and this was a large collaboration internationally. We got 159 cases and were able to show that there was mutual exclusivity of the BCOR internal tandem duplication, which we found in 83% of our cohort. We had a handful of cases with YAWE not M2 fusions, and the remaining cases had neither of these, and any case that had YAWE not M2 did not have a BCOR internal tandem duplication. Subsequently, it was published that BCOR rearrangements could also occur in CCSK. And so we contributed with others to this concept of the BCOR family of tumours, which includes not only CCSK, but also high-grade endometrial stromal sarcoma, primitive myxoid mesenchymal tumour of infancy, undifferentiated round cell sarcoma of infancy, and a BCOR high-grade neuroectodermal tumour. All of these very different entities may be driven either by a BCOR internal tandem duplication, in a few cases a BCOR rearrangement, or indeed the 1433 epsilon not M2 fusion. And so there is a common underpinning, if you like, to all of these different entities. Malignant rhabdoid tumour of the kidney is one of the most aggressive tumours known to mankind, and typically occurs within the first 2 to 3 years of life, often being an infantile tumour. And despite the fact that there is biallelic inactivation of just one gene in this tumour, the SMARCB1 gene typically, sometimes SMARCA4 instead, this is a highly aggressive tumour, which is somewhat surprising until you understand the biology. In about a third of cases, so 35% of patients, will have a germline predisposition. And if it is SMARCB1 that is germline inactivated, we call this the rhabdoid tumour predisposition syndrome 1. Rarely instead the patients have germline inactivation of SMARCA4, also known as BRG1, and this is known as rhabdoid tumour predisposition syndrome 2. For patients with a predisposition, they present a little bit earlier, even though this is already a tumour of very young age, and they may have synchronous or indeed metachronous tumours, and all children presenting with malignant rhabdoid tumour of the kidney should really be scanned for presence of atypical teratoid rhabdoid tumour, which occurs in the CNS. Malignant rhabdoid tumours can also occur in an extracranial, extrarenal location. The presentation median age is 11 months, so it's a very early presentation, and unfortunately the vast majority of these patients do very poorly because the tumour is not responsive to any great extent to chemotherapy, and they're in fact too young to have irradiation. The classic rhabdoid morphology is that of a large polygonal cell with very intensely eosinophilic intracytoplasmic inclusion, giving it its name rhabdoid because it looks a bit like a rhabdomyoblast. The nucleus is pushed off to the side, is vesicular, and typically has a macronucleolar appearance with eosinophilic characteristics. Now, sometimes these inclusions are absent, and so it is in fact the nuclear features that are more consistently present in rhabdoid tumours. The characteristic feature, of course, on immunohistochemistry is the loss of SMARCB1 staining, and you can see that all of the tumour nuclei here are negative, and we have a nice internal positive control of endothelial cells that still stain, as well as some infiltrating lymphocytes. So apart from using immunohistochemistry as a surrogate marker of SMARCB1 loss, we can also detect this by either fluorescence in situ hybridization or next generation sequencing. The SMARCB1 gene and similarly SMARCA4 are members of the SWI/SNF complex, which is an ATP-dependent chromatin remodeling complex. And loss of SMARCB1, which again, just biallelic inactivation of one gene, actually results in dysregulation of more than 1,300 genes because of the role of this complex. Normally, there's an imbalance between the SWI/SNF complex and the polycomb repressor complex 2, and this becomes unhinged or dysregulated when SMARCB1 is lost. And so EZH2, the catalytic domain of PRC2, becomes targetable. To date, however, monotherapy for EZH2 inhibitors has been quite disappointing in these tumours, and there are trials still ongoing combining EZH2 inhibitors with chemotherapy. Checkpoint inhibitor trials are also currently underway because this tumour really has a very poor outcome and we need better treatments. Congenital mesoblastic nephroma is congenital or infantile, usually happening within the first 6 months of life, but almost always within the first year of life. And therefore, unlike the presumptive treatment for Wilms tumor, because these patients are so young at presentation, we should have a suspicion immediately, and they're not treated preoperatively with chemotherapy, but if resectable, should really go immediately for surgery. Histologically, we have really 3 subtypes. The cellular subtype is characterized by an ETV6 NTRK3 fusion resulting from the 1215 chromosomal translocation. There are other potential translocations that may occur involving NTRK3 or NTRK1, or indeed in some cases the ALK gene. And these all result in constitutive tyrosine kinase activation. The classic form of congenital mesoblastic nephroma is somewhat less cellular, and actually these 2 entities recapitulate the soft tissue counterparts, which are congenital fibrosarcoma and congenital infantile fibrosarcoma fibromatosis in the case of classic CMN. We do see cases that have features of both the cellular and classic histology. The classic form typically shows a kinase domain duplication in the EGFR gene, or in other instances may have an internal rearrangement of BRAF, which results in loss of the domain that binds RAS, which is a regulatory domain, and therefore RAS becomes activated. Sometimes we see this BRAF internal rearrangement in the cellular form also. So here we have the histology, and in the upper fields, we can see this very cellular, fascicular looking arrangement of ovoid cells. And there is very high mitotic activity typically in these tumours, but also little zones of apoptosis are seen. And as areas become apoptotic, these blood lakes open up. These are not true vascular spaces, but they're very characteristic of cellular congenital mesoblastic nephroma. So this is the form that looks very similar to congenital infantile fibrosarcoma. We can see that the tumour often interdigitates with pre-existing renal elements, such as the tubules and glomeruli at the bottom left. And on the bottom right, we can see the classic congenital mesoblastic nephroma, a much pinker tumour, much less cellular, and similar to fibromatosis histologically. So this is the form that typically has the EGFR kinase domain duplication or the BRAF internal rearrangement. Now, whereas renal cell carcinomas make up less than 5% of all pediatric renal tumours, they are very important in the children over 10 years old, where they make up about 50% of the total. There have been some updates, and our paper was highlighted as challenges and updates. So I will give you something on the subclassification of these tumours, which really has come from molecular and morphologic insights in the last few years. The big challenge for these tumours, however, is treatment. So they tend to be chemo and radiation insensitive, and so surgery is still the mainstay, and we badly need more therapeutic targets. In the pediatric setting, the vast majority of renal cell carcinomas, more than 50%, are due to microphthalmia transcription factor translocations. And the commonest form is TFE3 rearrangement. TFE3 is on XP11, the short arm of chromosome X. This more commonly is underpinning the tumour than a TFEB amplification, which in turn is more common than rearrangement of TFEB. Many different partners may fuse with TFE3, and of note, MED15, when it's fused with TFE3, produces a multicystic tumour with an appearance similar to the multicystic renal tumour of unknown malignant potential. But immunohistochemically, that same tumour still stains just the same as the translocation-associated renal cell carcinomas. The TFE3 rearranged cases tend to have a very classic appearance with papillary architecture, with the papillae lined by clear lining cells and containing numerous somomatous calcifications. And we can see here a low power view of the case, and here papillae lined by clear cells with multiple somoma bodies. We often will find some pigmentation of these tumours, and they do stain for melanocytic markers. Now, importantly, they're negative for cytokeratin, EMA, and carbonic anhydrase 9, all of which should stain clear cell carcinoma of the kidney, and therefore that should aid in the differential diagnosis. These tumours are positive for cathepsin K and GPNNB, a new marker that I'm going to tell you a little bit about. And if there's doubt, PAX8 is also helpful for revealing renal origin of these tumours. So again, either by immunohistochemical means or indeed by FISH or next generation sequencing, we can demonstrate high nuclear expression of, in this case, TFE3, and in the next slide, TFEB. And at the bottom, I'm showing you cathepsin K staining. So this is a case with TFEB rearrangement, and you can see the nuclear staining for TFEB. These tumours may often exhibit a biphasic pattern, wherein we have the cleared cells forming sheets and surrounding small nodules or aggregates of darker staining epithelioid cells. And again, we have some pigmentation in this case and some staining with melanocytic markers, as well as reactivity for GPNNB. So GPNNB is a relatively newer immunohistochemical stain that was identified as being positive in TSC1, 2, and mTOR pathway associated renal tumours, and also the microphthalmia transcription factor family associated renal neoplasms. So then there is a relatively newer entity that I want to mention also, because it is something that has come to light in the last number of years. So this is the eosinophilic solid and cystic renal cell carcinoma associated with TSC1 or TSC2 inactivating mutations. And usually this has a solid and cystic pattern of growth, as the name would suggest, and is composed of large cells with abundant eosinophilic cytoplasm and basophilic stippling. Historically, it was recognized as one of the potential patterns of renal cell carcinoma post-neuroblastoma. It had a brief entry into the WHO classification, became a provisional entity in 2016, but then was in fact eliminated in 2022. And even though this pattern may be associated with TSC1 or TSC2 inactivation, it is not the only pattern of renal cell carcinoma seen in that context. And it is also certainly not associated only with a history of neuroblastoma, but has also been described in other cases of previous cancers, such as medulloblastoma and glioma as well. So here's a pattern of solid and cystic growth, and the cells are perhaps reminiscent a little bit of ganglion cells. They are large, they're polygonal, they have this basophilic stippling, almost like Nissl substance, and these large vesicular nuclei. There may be some staining for cytokeratin 20. This can be very patchy, as in this case, or more diffuse. And GPNNB is also present as well. So here we can see the pathway, and with inactivation of either TSC1 or TSC2, we lose the inhibition of mTOR downstream, and therefore mTOR becomes targetable. So, for example, rapamycin could be used in these cases. So understanding the biology really is very important. The other thing to note is that these cases may arise in the context of true tuberous sclerosis syndrome, and then background angiomyolipomata may be found within the kidney, but it can be a sporadic event. ALK-rearranged renal cell carcinoma is typically a well-circumscribed tumor with peripheral inflammation, and it may be associated with sickle cell trait. The commonest rearrangement is ALK1-VCL, and there is a characteristic appearance to the histology here, whereas when other few genes are fused with ALK, the appearance may be quite different. So the classic appearance when it's ALK1-VCL rearrangement is one of large cells with vacuolation. And of course, because of the sickle background, we may see some of the red cells showing some sickling. Importantly here, we will have staining for ALK1, as you might expect, but also for cytokeratin 7, PAX8, EMA, and in 50% of cases, OCT3 or OCT4 positive. SMARTB1, importantly, is retained, and that's really important when we have a case associated with sickle cell trait that we don't want to confuse with renal medullary carcinoma. The rearrangements of ALK, of course, can be detected again by FISH or NGS. This is one of the high-grade pediatric renal cell carcinomas, along with fumarate deficient and SMARTB1 deficient renal cell carcinomas. And then the final form I'm going to talk about is renal medullary carcinoma, also known as the 7th sickle cell nephropathy. This is a very, very poor actor. Most patients actually only survive for about 8 months on average post-diagnosis. It's usually an infiltrative mass as opposed to the ALK mass, which is usually circumscribed. And it is diffusely positive for a spectrum of keratins and fomentin, and 50% again are positive for OCT3, 4. It is ALK negative, of course, and SMARTB1 is lost in this tumor. So this is additional help in differentiating it from the ALK rearranged cases.
Maureen, I'm sorry.
Several targeted therapies for renal medullary carcinoma underway currently, and you can understand how tazemetostat, an EZH2 inhibitor, would have its role given the loss of SMARTB1. There are other many different opportunities that are arising from a better understanding of the biology of these various tumors, as you can see here. Because at the moment, it is still just surgery that is the mainstay. But for us as pathologists, everything hinges on accurate histological and molecular diagnostics to give our patients the best opportunities for optimum therapeutics. Thank you very much for your attention. And I apologize, I believe I've gone a little over time, but I'd be happy to take any questions at the end. Thank you.
Thank you, Maureen. It's wonderful, and I'm sorry we were short of time, but questions at the end. We know we are running late, so we will have 10 additional minutes for questions. So it is my pleasure now to introduce our next and final speaker, Dr. Claudia Salgado, who will be presenting on a congenital melanocytic neoplasm. Claudia is very well known to all. She works as a pediatric and perinatal pathologist at the University of Miami Miller School of Medicine and Jackson Health System, where she's also the medical director of anatomic pathology operations, and she's actively participated in many societies like IPA, Society of Paediatric Pathology and also the Latin American Paediatric Pathology Society. Thank you, Claudia.
Thank you. Thank you, Marta. Can you hear me well?
Yes.
Okay, let's start here. I will try to be as brief as possible to give us time for questions. So it's a pleasure to be here. Thank you, Marta. Thank you, Isabel and Miguel, for the invitation to be here. And I will be presenting today our work in congenital melanocytic lesions in the pediatric population. Just 1 minute. I have no conflict to declare. So that's the outline of my presentation. I will be starting giving a brief review of the disease that we'll be talking about, try us to understand why our pathology report is so important for the life of these little patients. And then I will start reviewing our approach to the diagnosis and treatment of these lesions. So my story of this lesion started in 2012 when I was a postdoc fellow at the Department of Developmental Biology at Pittsburgh, and I received an invitation to present at their conference. This is a patient conference, a survey that they have in their website. As any other self-reported survey, you have a lot of bias. I never published that evaluation, but make me aware of their problems and how our daily life, our fears, their fears of the malignant transformation of these lesions. The lesion is classically classified by the size of the melanocytic nevi, or the projected size in adult life, in small, as we can see here, medium, and large giant nevi. And besides of the statistical problems, we have additional problems like atrophy and thickening. And you can imagine someone to live with lesions like that. But the most important complication that this patient has and should be detected by MRI done in the first 6 months of age is the proliferation of these melanocytic lesions in the central nervous system. That depending on the location of these kind of benign lesions can have very dramatic symptoms for these patients as hydrocephalus, seizure, and even the malignant transformation of these central nervous system lesions. The removal of these lesions is very complex and difficult in the skin and in the brain, in the central nervous system. And when treated with abrasion, like we can see on the top back here, this lesion in general return. So our classical pathology report for melanocytic lesions that say a typical melanocytic proliferation, full resection is advised. In this particular case, will not be helpful for our patient. We can do much better than that. We need to do much better than that. So the classical nevus, we have no problem, the classical congenital nevus. And we can see here the composition of this classical lesion coming from the bottom, from spindle cells, very bland with neuronal type of appearance, to the round cells with infiltration of skin adnexa, and the top, more mature cells, melanocytes, with more cytoplasm, larger cells, and pigment. In general, very low proliferative index. And the pathogenesis of these lesions is well known now, is caused by a somatic mutation in neurocrest-derived precursor melanocyte cells, that is the same cells as a Schwann cell precursor. For a kind of a long time, Dr. Bastian and Dr. Kinsler had to report that the majority of these cases are driven by NRAS mutation. So to try to test this hypothesis in Pittsburgh at my time in the lab. We generate a transgenic mice with NRAS in these precursor cells. And for our surprise, no melanocytic lesion appear. So it seems like we need more things. And now we know that the MAP pathway has multiple regulatory processes, including accessory proteins and integrations with other pathways that can change the manifestations of these mutated cells. And this is after our time there, I think it's last year progression of our mouse model. And with the addition of the hepatocyte growth factor to the model, as we can see here, now our mouse model demonstrate the same manifestation in the skin and the central nervous system that we can see in our patients. But not only in RAS. So in 2015, we published that some of these cases are also can have BRAF mutation. And very interesting, we were first note that these patients with BRAF alterations have these subcutaneous nodules, as we can see here in the picture. Our findings were posteriorly confirmed, and I'm showing here two more recent papers, the last one here from 2024, that show not only NRAS, but also other MAP kinase pathway, including BRAF mutation and fusions, can be the cause of these lesions. And also the same thing that we published in 2023 in 2015 is shown here, more subcutaneous nodules. And if we look at the histology of these subcutaneous nodules, it's very interesting. We can see here in the scan magnification parts that look like a congenital melanocytic nevi and a very well circumscribed nodule composed by cells that look like Schwannian cells, and some of them has this ganglion cell appearance, like a ganglioneuroma. And this is the expression of X100 in this nodule. Very strong expression in most of the cells. Maybe the ganglion cells apparent one is the one that has a weaker stain. This is very well known. Most of the descriptions of congenital lesions show that in the deeper part of these lesions, the Schwannian cell appearance can be present, like we can see here. And if we look very close, you have this palisading appearance of verrucate bodies that we can see in schwannoma. Also not very surprised, because we know now that the precursor of melanocytes is the same Schwannian cell precursors. This is very well demonstrated in this publication from Dr. Irina Kletiskaya, that she showed that many of these nodules that we can see in congenital melanocytic proliferations are composed by Schwannian and perineuratose cells with differentiation. And just showing one of her cases here is very similar to our nodules. And this particular case show a diffuse neurofibroma-like type of appearance. And I'm using her description to catch your eyes for the next histologic finding that I would like to pay your attention. The presence of mast cells. I think we as a pathology overlook of this, but this could be a very important clue for the clinical team to treat one of the most important and distressful manifestations and symptoms for these patients. These patients have a lot of pruritus in their lesions. And as shown here, we show in a case report before, and then in a large analysis in this case, that these lesions has an increased number of mast cells. And this pruritus can be successfully treated with serotonin 5 type 3 receptor blocker. So there is an important information that you can put in your report that will improve the life of these patients. But I think the worst that is for us as a pathology and for the patient is the progression of the disease. The risk of malignant transformation is a main concern for them and for us as a pathologist. So it can occur at any time of the life of these patients, but in general is more frequent during childhood and adolescence. The overall risk is very low, but increase a lot in patients with large and giant lesions, about 10 to 15%. And although the majority of the malignant transformations occur in the skin in kids, the proportion of CNS malignancies, which is very aggressive, as I will show you some cases, is very increased significantly. And the problem for us is all the criteria that you have for adult population to diagnose melanoma does not apply pretty well in young patients. So it's very difficult, and sometimes we need to be able to tell them that we are not sure. The other major problem for us, that is not only one pathway that will lead to malignant transformation in this lesion. There is many different pathways that can trigger the malignant transformation in these patients. So for us pathologists, the lesions that has high proliferative index is very suspicious for malignant. But I'm putting here two experimental works, one from our lab and one for a recent paper that was published in Cell that show the initial phase. You have a lot of nerve cells, benign nerve cells that are proliferating, and then they go to senescence. It's the same in the mouse models. Here we can see in red the proliferative cells and the senescent cells. So in the adult, all the cells will be in senescence and just a few cells will be proliferating. But in a small patient, in a newborn patient, in the first 6 months of life, we have a lot of nerve cells that are proliferating and they are not malignant because of that. So you cannot trust in presence of mitosis in the first month of age to make the diagnosis of a melanoma. And that brings me to the one of more difficult cases in these lesions, that what we call proliferative nodules. And I'm using this paper to show that here we have all the criteria that we traditionally use to diagnose malignancy in melanocytic lesions. And some of them are present in what we call atypical proliferative nodule, that by definition is not a melanoma. So some of the proliferative nodules can have all the features or some of the features that you use to classify malignant melanoma. So we need to be very careful, mostly in small pediatric cases, small lesions before 6 months of age. So we need help. So where we can find help? In these particular cases, some immunostains, and I'm citing here one of the most useful one that was published by the group of Dr. Buzan, showing that the melanomas or the malignant transformated lesions has reduced expression of the A3K27 and E3. Like we can see here in the proliferative nodules, the expression is retained and is lost in melanoma. But in the same paper, he showed cases of melanoma with preserved expression. So it's helpful, but will not solve all of our problems. The next stain that is used a lot in the adult population to differentiate malignant versus benign proliferation is the PRAME. So the original paper by Dr. Cecilia Lascano only have 2 cases of congenital nevus, so it's not validated for this particular type of lesions, but we have more papers that were published after that. So most of the papers, like the one that I'm showing here, is more in adult population. Some cases, like the second one by the Dr. Torres Cabala, is just a case report, and so that could be helpful. But if we look specifically in the pediatric melanoma compared to the adult melanoma, PRIME can have lower expression. So we need to be aware of that. And also some proliferative nodules, like 2 cases published by Dr. Pedro Gerami of proliferative nodules, can have expression of PRIME without being a melanoma. So is useful, but we need to use it with care. So I'm using this particular paper to go to the molecular help, how we can have for the molecular side to help us to make the diagnosis or differentiation between malignant and benign. Maybe here we have the third promoter mutation. So tumors with third promoter mutations have more chance to have malignant transformation. But I think the most consistent finding that is associated with malignant transformation in these congenital lesions are the copy number changes in the skin, as shown here in this publication by Dr. Bastian, and in the central nervous system, as shown here in this paper by Dr. Veronica Kinsler. We also found that the amplification of the mutated NRAS could be one of the mechanisms of malignant transformation, as I can show here in this case with a very large malignant nodular melanoma and a metastasis here in the liver. This patient has multiple metastases. I'm just showing one of them here. And the copy number changes was also most consistent change that we found in our series of proved lethal melanoma in kids using the methylation profile. All our cases of malignant transformation has copy number changes. And I will use this poster also to show that when we compare our cases, the malignant transformation of these lesions with the classical adult melanoma, the methylation profile is completely different. And maybe this explains why this patient does not respond well to the traditional treatment for adult melanoma. Is kind of a different disease. And only the large nevi are at risk of malignant transformation, not really. If you remember, that's the picture of my first slide showing a little baby with small, maybe medium-sized nevi, multiple, but not too many. I think he has 10, 15 nevi. And he progressed to the disease that I'm showing here in the slide. I think this particular case, no one will have question and will call benign. This is malignant clinically and histologically. The problem is not all the cases are very clear-cut like this. So how we can report this? So I think we have two big groups of lesions. One is clearly benign, and please call benign. And the other is clearly malignant, and we can do this. But a lot of times we are in the middle of these two extremes, and we have help of the immunohistochemistry, help of the molecular profile. If these two tools cannot make you sure if it is malignant or benign, please put in the report your questions and say that we don't have enough to say how will be the behavior of these lesions. And the molecular analysis in selected cases can provide to the clinical team some additional information that will be helpful for treatment. Why? Because now we have many inhibitors that can be used, and I'm showing here a table from our manuscript showing all the drugs that has been tested for the treatment of this type of lesions. Unfortunately, with not very a lot of success, and I'm showing you from our work in the lab why. So like I showed in the beginning, the RAF pathway interact with many other pathways. So if we block here, we have overstimulation of other pathways. And at least in our experimental data, we need to block many different points of these pathways and accessory pathways to get the results. And this is very toxic. This is also shown in this beautiful paper that was published a few years ago in Cell with a successful treatment, topical treatment with multiple drugs targeting multiple points like here MEK and PI3 kinase and c-KIT in a topical treatment. Unfortunately, most of these patients die of central nervous system disease, and this could be very helpful for cutaneous lesion, but the central nervous system will need to improve much more than that. So I would like to finish thanking our group and Pittsburgh lab. This was the group that worked with me and Miguel for a very long time in Pittsburgh. Thank you to all of them. This, what I present, is largely part of their work. And I'm open for questions. Thank you.
Thank you, Claudia. Thank you, Maureen, and thank you, Gino. We are a little short of time. We have a few minutes for possible questions. There have been a couple of questions in the chat. One of them is for Maureen from our colleague in Paris, Aurore Colombe, and she's asking about how to interpret cytoplasmic .ini1 staining in rhabdoid cells in MRTK. Could it be the link to missense SMARCB1 mutation? Maureen.
Yeah, this is a very interesting question. So in ATRT, we do tend to see some cytoplasmic staining of SMARCB1 potentially. And I think it depends on the type of mutation. So you're getting at the heart of the matter with your question, Aurore. Usually there's a nuclear localization sequence within SMARCB1. And the work that we did on rhabdoid tumor in the past, we reintroduced SMARCB1 and then studied the cell, if you like, in a reverse of a rhabdoid tumor cell line. But Andy Hong, our colleague in the States, has actually used a truncated SMARCB1 and reintroduced that and shown that it ends up as a cytoplasmic protein rather than nuclear. Obviously, it should normally be nuclear. And this is similar to what's happening in the ATRTs. So if you lose the very C-terminal sequence of the protein, then the nuclear exportation signal, sorry, not localization, becomes unmasked, if you like, and therefore the protein can be expelled from the nucleus or exported from the nucleus into the cytoplasm. And in fact, some work has been done. So I didn't focus on ATRT when we were working on SMARCB1. We focused completely on MRTK, the interest in renal tumours. But there is a group in Germany, Frühwald and colleagues, and they have attempted to block the nuclear exportation of this truncated SMARCB1 in cases where they found it, to actually get the truncated SMARCB1 back into the nucleus and restore some SMARCB1 function as a therapeutic option. So that is a very interesting development. And maybe that's what you're seeing in your MRTK situation as well, that you've simply got truncation of the very C-terminal part of that. I mean, we could go into what antibodies are being used, et cetera, too, but I presume you're just using BAF47. But hopefully that is some bit of an explanation for what you're observing.
Thank you, Maureen. There is another question for Claudia. What is the panel of tests by immunohistochemistry or molecular that you do for lesions of intermediate morphology to decide whether malignancy is present or not?
I think the Ki-67 helps if it is not a young patient. So if you see a very proliferative, if it is a small patient, proliferation is not a good clue. But if you have high Ki, is one thing. The histone 3 ME27, the big name, is also very, very helpful. Prime could be helpful, but with care. All these three will be helpful. I'm not talking about spitzoid lesions. I'm talking about congenital melanocytic lesions. And additional molecular analysis, copy number changes, is very helpful. I think if you have a lot of copy number changes can be helpful. And molecular analysis, looking for the genetic mutations, could be targetable. The people are using MEK inhibitor for this type of patients. So molecular analysis can also be helpful.
Thank you, Claudia.
How about you, Miguel?
Well, I think that ME3, methylation ME3 is the most useful in my practice. As you know, when we receive consults, when that one is lost, we are confronting a bad actor. But there is nothing absolute in these lesions, as they may have very different kinds of expressions, methylations, etc. We are at 8 minutes after 9 in the Eastern time. So we are running at the end. I would like to thank Dr. Abbas Agaimi for allowing us to publish this special issue in the Fisher's Archive. All the authors that contributed, Marta Cohen, whose support with the Royal College of Pathologists has really received a sounding welcome around the world, and all the participants. We had over 120 participants today. Our speakers, Maureen, Claudia, and Gino, whose excellent conferences highlighted the value of pediatric pathology, and the staff, Kristen and the staff at Royal College of Pathologists, for hosting these wonderful webinars.